Moving on to the next session, which will be dealing onto the hematology slides. This is mainly focused for the exam going students. So we have Dr. Sweta Rajpal. Ma'am is a professor in the Department of Hematopathology at ATRACT. So ma'am will be presenting and explaining in detail regarding the slides which we will be discussing in our practical exams. And before proceeding to the session, I would also like to thank Dr. Ashwin and Dr. Nitya Priya for being actively involved in this. Thank you all. And now we are moving to the next session. Shweta ma'am, handing over the session to you. Thank you.
Thank you. I'll be taking few cases that are common in hematology. So before going to cases per se, let's look at the morphology of normal cells in the peripheral blood. So what are these cells that you see? These four-lobed, this I think is five-lobe, three-lobed cells that we see here on morphology in the peripheral blood. Let me see if we are getting, okay. Yeah, so neutrophil, correct. So yes, so we see neutrophils here. Then if we go further, what are these cells? What is this cell? Smallest cell in the peripheral blood, clump chromatin, scant amount of cytoplasm. This is a lymphocyte. Then what is this cell? Gray cytoplasm, nuclei less mature, I mean less condensed as compared to lymphocyte, and kidney shaped kind of nuclei here we see. So these are monocytes. And this cell, what we see here is red granules. This is trilobe, but usually these are bilobed. So eosinophil. And this cell that has dense granule in such a way that sometimes we are not able to appreciate the nuclei also. So this is a basophil. Okay. So these are the common cells that we see normally on the smear. So before going to cases per se, I thought I'll just revise what are the cells we see in the smears. So case one is a 12-year-old girl who presented with fever and shortness of breath, mediastinal lymphadenopathy, generalized lymphadenopathy. In hemogram, the hemogram was nearly preserved with slightly elevated leukocyte count. So here, if I consider that if it is a leukemia, what kind of leukemia will we think of? Mediastinal mass, what leukemia will we think of? Yes. So I got answer TLL, T lymphoblastic leukemia. Okay. So we performed a bone marrow aspirate. The bone marrow aspirate was particulate, normocellular for age. We could see these cells. These are megakaryocytes. And when we went to the higher power, we could appreciate normal cells, as in we could appreciate normal erythroid precursors. So these are normal erythroid precursors that we see. This one is the early erythroid precursor, basophilic cytoplasm, and as it matures, the nuclei gets condensed and we can appreciate some lighter chromatin and dense chromatin. It appears like this, and there's polychromasia in the cytoplasm, that is blue and RBC kind of mixture color that we are seeing here. This was completely blue, but here it is a little mix of red and blue. And as these mature, they become like that. So these are erythroid series. This is neutrophil, and these blasts were there. So around 30-40% of these blasts that we could see, but we could appreciate normal hematopoietic elements. So this kind of picture we commonly see in especially T-ALL or T lymphoblastic leukemia, where predominantly you will have mass in mediastinum or somewhere else, and it will be infiltrating marrow. So it will be normal cells will be preserved. So this kind of morphology we see. So if you wish to describe blasts, you see, so as compared to what we saw in lymphocytes. So let's see here if we can appreciate a lymphocyte here. Maybe this is a lymphocyte. So as compared to this, these are your blast. Okay, these are your blasts. As compared to this, the chromatin is a little opened up. We can see some nucleoli, scant amount of agranular cytoplasm. So these are how our lymphoblasts look like commonly. So, but And we performed our cytochemical MPO stain, which were negative in these blasts. So this is a positive control, which was showing these granules, black granules that we could appreciate, but they were negative in the blast. So at the end of it, should we write that it is acute lymphoblastic leukemia by looking at morphology? So we just limit to saying it is acute lymphoblastic leukemia. We don't say unless, we just limit to saying acute leukemia, and we don't go for labeling it as lymphoblastic or myeloid series or mixed phenotypic based on morphology. We have to perform flow cytometry for saying that. Okay. So someone told that tell us about normal color. So about the erythroid color that I was telling of normal maturation, it is like this only. These are different maturation stage of normal erythroid precursor. This one is early, and these are intermediate where they are having polychromatic cytoplasm. And this is early, that is having basophilic or blue cytoplasm. So early erythroid are rich in RNA, so they will have blue cytoplasm, and as it matures, it will gain color, the hemoglobinization will happen, and it will gain a mix of blue and pink color. Okay. So this case is a case of acute leukemia. Here we say at morphology, we say only acute leukemia. But with the clinical picture, we would guess that it would be most likely T lymphoblastic leukemia, and we would perform flow and see. So this case was a case of TLL. I've not shown flow plots. I'm just going with morphology for this presentation. So case 2 is a 32-year-old male who presented with body pain and low-grade fever for 1 month, and patient was found to be have anemia and was transfused with 4 packed red blood cell. In addition, patient had some history of constipation and perianal fissure with mild bleeding after passing stool, but no hepatosplenomegaly or lymphadenopathy. And here what we can see as compared to the previous, these all are blast. This is a bone marrow aspirate, which is showing that most of the cell we see in this smear or this view is our blast. And here what we can see as compared to the previous case where the cytoplasm was very less, here there is relatively little more cytoplasm. And in the cytoplasm, we can appreciate these long things. So what are these? Okay. So someone has said or rod. Um, so yes, these are or rod. So these are long, thin, slender or rod that we can see. Now here what we can see is there's opened up chromatin of the nuclei, and cytoplasm is little more as compared to the this thing. So at when we look at such kind of morphology, can we confidently call that this is AML? Someone says APML. So, mhm. So someone says that it is APML, but it would not be, we cannot call it APML because even other AMLs may have OROD. So one of the AML that classically has long slender OROD is AML with translocation 821 or RUNX1, RUNX1 T1. And someone has asked, how can we differentiate between peripheral blood and bone marrow? So basically, when you look at the smear, bone marrow will have evidence of bone marrow cellularity. So initially, when I showed you peripheral blood smears where we could see RBCs and we could see neutrophil, lymphocyte, monocyte, eosinophil, but that was normal. Suppose in this case had many blasts in the peripheral blood also. So how do we differentiate if the smear is from peripheral blood or bone marrow? So bone marrow aspirate most of the time has particles. So what I showed in the first case, let me go back to the first case. Okay. This is a particle. So what we have, fat spaces and cellular areas So this is something that we see in bone marrow only. We don't see in peripheral blood. And we also see megakaryocytes in bone marrow, which we do not see in peripheral blood. So this is how we can differentiate between peripheral blood and bone marrow. Okay. So now at this point, we are seeing blasts that are having long slender rod. And when we looked at MPO, we could see positivity. So all the blasts are showing positivity for MPO. Here, these are in form of these black granules that we can see positivity. So at this stage, can I call it AML? So OR rods are lineage defining. So yes, I can call that there should be myeloid lineage in this, but calling it AML at this point, because we have not ruled out a second component. I mean, if it is a mixed phenotypic acute leukemia, where we are having either T or B component, that we cannot say. So, but looking at the morphology where we have long slender OR rods, so we can say that most likely it would be AML with RunX1, RunX1 T1. So other features in morphology that we see is we can see disc granulopoiesis, neutrophils that are dysbiotic as compared to normal. That also helps us to think in form of AML with RunX1, RunX1 T1. But for all practical purposes, on morphology, we don't go ahead and commit for lineage because of the fact that before the patient receives therapy, it is important to define the lineage, and flow cytometry becomes of utmost importance. So case 3, 25-year female presented with bleeding gums. On hemogram, she had pancytopenia. And this was a bone marrow aspirate. Now we can see these cells that are there. Okay. So here you can see multiple OR rods that are seen in single cell. And if you look at the cytoplasm of these cells, we can see a lot of granules. Unlike the previous case, there were some granules. Here there are a lot of granules that are seen, and there are multiple OR rods. And when we performed MPO, this was strongly positive. Now this case is, yes. So now this case is acute promyelocytic leukemia, where we are seeing abnormal promyelocytes and which are strongly MPO positive. So let me go back and show you that, if you can appreciate this cell, there are two nuclei that are convoluted kind of thing. So you can see a partition here. There is a convolution that is there. Here also, there is a convolution in this nuclei here also. So these are also called buttock cells that are there that have a convolution, and there are multiple rods, which means fagot cells are present, and these are of acute promyelocytic leukemia. Okay, so this case is a case of acute promyelocytic leukemia, and we'll perform cytogenetics and confirm FISH for PML-RARA, and RT-PCR for PML-RARA will be performed for these cases. Now, case 4 is a 61 female who presented with fever on and off for 4 months, weight loss of 5 kg in recent 2 months. And patient had no lymphadenopathy but had splenomegaly and had leukocytosis of TLC of 74,000 with absolute lymphocyte count of 63,000. And these were the cells that we were seeing. So what are these that we can see, these cells? So yes, correct diagnosis. So there we are getting these mature kind of lymphocytes. So there is lymphocytosis, presence of smudge cells. So yes, this case is a case of chronic lymphocytic leukemia. And what kind of morphology we see when we look at the morphology of chronic lymphocytic leukemia, we see cells like this, I've gone to the higher power, and what you can appreciate, the chromatin is two different kind. One is like you can see a soccer ball kind of appearance. This lines are there, which is giving it an appearance of a football. So that way, because chromatin is dense here, and then it becomes light here. So euchromatin and heterochromatin is there, and because of this, it gives a soccer ball kind of image. And these are the smudge cells that we see, and this we see classically in cases of chronic lymphocytic leukemia. Okay. Case 5 is a 42-year-old male who presented with pancytopenia and splenomegaly. And this was the cell that we saw. So what do we think the diagnosis is? Yes. So we are getting answer of hairy cell. Yes. So pancytopenia and splenomegaly. So as compared to the previous slide, what we can see is these cells are little larger. And can you appreciate these projections that are there? And cytoplasm is more, and we are seeing projection, and this chromatin is not as dense as we saw in the previous case. So this is a case of hairy cell leukemia. And 72-year-old male who presented with multiple lytic lesions. So what are these cells that we are seeing? Yes. So this case is a plasma multiple myeloma in bone marrow. We saw these cells, plasma cells that we were seeing. So these have eccentrically placed nuclei, clump chromatin, and basophilic cytoplasm we have. And some may show presence of HOF. Okay, perinuclear HOF is seen in these plasma cell. So this is a case of multiple myeloma. Okay. These were my cases. I'll be happy to take questions and any doubts if you have.
Hi, Shweta ma'am, Karan this side.
Yes, yes, yes.
So actually, a lot of requests came in to actually read the marrow,
Right,
stomach way, like cellularity, ME ratio,
right,
erythroid,
okay.
myeloid series. Could you please elaborate on the way that we have to report?
Sure, sure, sure. So let me open another this thing. So when we look at a marrow, what happens is that we look at the cellularity, what kind of cellularity we are seeing. So we look at fat spaces and the particles per se. Okay, just give me a minute. I'll just open another presentation. I can show via that maybe.
If anyone has any doubts, please post in the question answer panel.
So this is something that I had prepared. So if you look at this, this is something that is called a particle. Okay. So now here what we can see is we can see only fat spaces. We do not see any cellular component. Unlike the previous case where we saw a normocellular marrow where we could see cellular component were there. But here what we see is these are only fat spaces that we see. Okay. So this is a hypocellular aspirate. And if you look at the first case that I had shown, yeah. So here, these are area of cellular areas and these are fat spaces that are there. Okay. Fat spaces have clearly defined edges. And when we look at bone marrow, we first look at in low power how particles if we are seeing or not. We look at cellularity, where we try to look at how much is it normocellular, is it hypocellular, is it hypercellular. So what do we mean by cellularity? So how do we say when it is normocellular? So for being normocellular, it is the criteria is 100 minus age. So suppose a 60-year-old patient comes to you. So the cellularity, normal cellularity that you'll expect is 40%. That means 40% will be your cellular spaces and 60% will be fat spaces. Okay. So according to that, we call normo or hypocellular or hypercellular. But aspirate is not the ideal place to finalize the cellularity. It is the bone marrow biopsy where the comment of cellularity should be taken definitely. I mean, if you are getting hypocellular marrow spaces in bone marrow biopsy, then that should definitely be considered as hypocellular. Now, next thing that we look at is megakaryocytes that we see. Okay, megakaryocyte adequacy that we see. If we see 3 to 5 megakaryocyte per slide, we call it adequate. And around a particle, if we are getting more than say 6 or 7 megakaryocyte, we call it increased megakaryocyte. Okay. Now, then we go to myeloid to erythroid ratio. So what we do is we give a count on myeloid series cells, and we count the erythroid, and we take the ratio. So normally we get ratio between 2:1 to 5:1 kind of thing, where myeloid is more as compared to erythroid. Whenever we have situation where we have MDS, or we have megaloblastic anemia there, or any regeneration that is happening where erythroid series increases and we see erythroid hyperplasia. Similarly, if we have myeloid preponderant marrow, for example, cases of CML, there we can see a extremely reduced a megakaryocyte. Okay. So now I'm getting questions for normal findings for CML. Okay. And MPO staining. Okay. Okay. So now, if we look at a CML, what findings we see in a case of CML are, we see a shift to left. So what we will see is that we will see myelocyte, metamyelocytes, and some blast. If it is not in blast crisis, it will be less than 20%. If it is in blast crisis, it may be more than 20% in the peripheral blood also. Now we see them, and in addition, important finding is basophilia that we see in the peripheral blood for cases of CML. And if we look at we see the same thing in peripheral blood and bone marrow aspirate. We see a completely packed marrow where we will have hypercellular marrow, and dwarf form of megakaryocytes are very common, where we will have megakaryocyte will be increased and small megakaryocytes will be there. So that is something that we see, and shift to left and basophilia is always there for cases of CML. Now, if we see the question, how we can differentiate between AML and ALL on peripheral blood without MPO stain, we cannot differentiate between AML, ALL without MPO stain, or in fact, without flow cytometry. It is very difficult to go ahead and commit for these lineage. As I said, that you have to perform flow cytometry, because you are once any patient that will be receiving therapy, you need a definite lineage before going ahead with the therapy for these cases. Yeah, I think.
And we have one more question also, ma'am.
Mhm.
MPO staining is much darker. How to differentiate from Sudan black?
Right. So basically, it depends on what dye you are using. By using, if you use DAB or diaminobenzidine, it will be brown in color. But in our this thing lab, we are not using DAB. We are using a chromogen that gives a black color. Usually, it is supposed to be brown in color. But if you are using a chromogen that gives a black staining, then you will see something like this. So that is okay. It depends on ye. So you won't be able to differentiate between Sudan black versus MPO just by looking at the slide. It will be like you will have to know that is it what staining has been performed. Then only you'll be able to say that if it is Sudan black or MPO per se. Yes.
Ma'am, a bit about DLBCL and HL, ma'am, if possible.
Okay. So DLBCL and Hodgkin lymphoma, you mean?
Ma'am, yes, ma'am.
Okay, so basically what you see in DLBCL, you will have large cells. It will be difficult to differentiate between blast and these cells. When you look at morphology of them, they will have something like large cells will be there with scant amount of cytoplasm, which will be looking blastoid to you. But based on history and everything, lymphadenopathy and all, we go ahead and perform flow cytometry panel and then label it as DLBCL versus acute leukemia. So it is very difficult to differentiate based on morphology for DLBCL. In Hodgkin lymphoma, if you look at bone marrow aspirates, in aspirates, it is very, very, very uncommon for you to find any findings, because if bone marrow is involved, generally bone marrow will have fibrosis. So once there is fibrosis, to tap bone marrow aspirate, it becomes very, very difficult. So you won't be able to get a cellular tap. Okay, so then what you can see is one thing, if you see, you may see in bone marrow biopsy. Okay, in bone marrow biopsy, you may see areas of fibrosis, you may see Reed-Sternberg cell that are there. So that may be present in bone marrow biopsy, but per se in bone marrow aspirate, there are case reports only of Hodgkin lymphoma being seen on morphology per se. Yes.
And we can take a last question. That can you please explain regarding the myeloid bulge in CML?
Correct. So CML is a disorder where you are getting increased number of myeloid series. So when we look at myeloid to erythroid ratio, I told you that normally we get between 2:1 is to 5:1 kind of thing. But in CMLs, we get a myeloid to erythroid ratio of 49:1. That means the myeloid series are so many that you, in your count of 100, you will just be getting 1 or 2 erythroid series. Okay. So CML is a disorder where all the stages of myeloid series will be expanded. So you will get many myelocyte, metamyelocyte, myeloid blast that will be increased. So that is why it is called myeloid bulge, which will be suppressing your erythroid precursors, and you will get a few erythroid precursors only.
Thank you, Sweta ma'am, for such wonderful and crisp presentation. Hope all the students have noted down everything what ma'am has told. It was really good, ma'am. Thank you so much. Now we are moving on to the next speaker. It's regarding the discussion on cytogenetics and molecular oncology. It's by Dr. Vidya Harini Veldore. Ma'am is a PhD holder in molecular oncology and an alumni of IISc Bangalore. So she'll be explaining us a bit regarding the cytogenetics and molecular oncology. Ma'am, the session is to you.
Thank you so much for this invitation, and I'm glad that I'm.
Ma'am, you're not audible, ma'am.
Hello, can you hear me?
Yes, ma'am, you're there.
Yes, yes. So, thank you so much for this invitation, and I'm glad I'm interacting with the in a clinical group here. So, could you share the slides, or how do you want me to do it? I'll do it myself.
Sure,
I
ma'am. You
do
can
it
share it on
myself.
your own, ma'am.
Yeah, sure. So the topic of discussion today that was assigned to me was essentially to discuss about 3 to 4 topics on chronic myeloid leukemia, as well as on BRCA1 and BRCA2 reports, and then what is the meaning of pathogenic, likely pathogenic, and how does it has implications when you vary between pathogenic and likely pathogenic in your real world scenario when you are actually trying to interpret the results from an NGS testing. And then in beyond BRCA1 and BRCA2 by NGS, is there anything? Yes, if there is a strong family history, we need to rule out large deletions and duplications by a technology called MLPA, which essentially look at more than 1 kb, 500 MB to 1 kb and beyond large deletions in the human genome within the BRCA1 and BRCA2 genes. And then moving on to CML, I will be walking through qPCR dummy report as well as an IRMA dummy report, explaining how we interpret the results for BCR-ABL measurement, and then background on cytogenetics and FISH, and then a brief overview on important components of NGS report and its relevance in the routine clinical practice. My screen is visible, right? Hello?
Yes, ma'am.
Yes, ma'am,
Yeah.
you're there, you're there.
Yeah. Yes, thank you. So, in the interest of every one of us, it's always better to look beyond BRCA, because there is so much of evidence that has been coming up from India as well as from the rest of the world, that when you have a classical HPOC, it is not necessary that it will always fit in BRCA1 and 2. You might have a mutation in RAD51 series or an ATM or a CHEK2. So it is very, or a PAL-B2. So it becomes very important to look beyond BRCA1 and 2, the remaining non-BRCA HRR genes also, in order to understand the familial risk associated in a given family. So in that interest, I'm elaborating on the 15 important genes which was first published at the time when olaparib was approved, FDA approved for high-grade serous ovarian cancer, as well as for prostate cancer, castration-resistant prostate cancer. So these are the genes, and in any given NGS testing, the most important thing that we need to verify is, if we are asking for a gene sequencing, what is the coverage of the genes? Are we getting 100% coverage? If we are getting less than 100% coverage, then the laboratory, if they are missing an important functional region, which I will be going through in the later slides, then it is important that lab mentions that, yes, it is only 75%, 95% covered or 97% covered. The remaining 3% does not involve any functionally relevant domain of the protein, and hence its impact may not be very significant, or at least give a submission that this particular tail end of the gene of last 10 amino acids is missed. Now moving on, this is the classical homologous recombination repair, which is playing an important role when there is a DNA double strand break in a HR proficient system. The homologous recombination pathway, which is a group of genes which are BRCA1 and BRCA2 associated genes, all of them come together and help in repairing the double-stranded DNA by joining the ends. And then you have the mutation that gets created. Once the mutation is created, then you know that the cell recognizes it as a foreigner, and then it takes it to senescence. In a cancer cell, when there is a mutation in any of the genes, this recombination pathway does not work efficiently, because of which the breaks remain, and there is a PARP enzyme that comes essentially to help this, and that the PARP enzyme, if you block it, then you are unable to repair the system. And that is the mechanism by which the drug action happens. So I'm just jumping now back to reading the BRCA report. We all talk about pathogenic, likely pathogenic, and VUS. Where did it all start? It started back in the year 2013. The very first guidelines were given by American College for Medical Genetics, and then subsequently, as and when the data increases in the public domain disease databases, there is improvement in these guidelines, and that is when they gave the first 5-tier classification of variants, which comes in the next slide. So any variant is nothing but a mutation. What is the mutation? It is a change in alphabet in the human DNA. And why did we call it a variant and then not a mutation? Because when you see a mutation can be like polymorphism also is a mutation, whereas a mutation happening in a cancer cell is also a mutation. But polymorphism is something which happens in 5% of the individuals, meaning every 5th person it is present, or 5 people in 100 people have this certain mutation. These mutations are SNPs or polymorphisms. In other words, these are different names for this. They don't have any health, disease impact. They are just the elements which distinguish all of us from each other, polymorphisms. Whereas a mutation is a rare event that happens 1 in 1,000 or 1 in 10,000 individuals. Because it is a rare event, and nature, when it makes this rare event, there is a purpose behind it. Most often it gets associated with a disease. And that's the reason why you call it a variant. And then I will go through a slight variation between why is it patho and likely patho. It all boils down to the scientific evidence level that is available. And then what is variant of uncertain significance, benign, likely benign and benign. So here it comes, how we understand this concept. So whenever you sequence a human DNA, the very first thing what you have to do is, as I said, this SNPs or polymorphisms, which all of us carry, and we are similar, different between each other. Like Asians have different polymorphisms as compared to Caucasians. Within India, the North Indian descent is more of an European ancestry, whereas the South Indian descent is more of a Dravidian ancestry. And therefore, we carry different types of polymorphisms in us. And the very first thing what you need to do when you collect the data for looking at an NGS or a Sanger or anything to understand a disease relevant mutations, the first thing is you have to remove all the polymorphisms which are present, because they are harmless. They are just present in different individuals across the globe. It's more of population specific. Therefore, you call it population databases. So there are many bodies which came up, independent bodies who came up and built, a repository of these polymorphisms. And it becomes important, the very first thing, to eliminate all these, because these are practically noise. Okay. And then we move on to disease databases. What are these disease databases? We all know ClinVar is one of the very well established databases, not just in oncology, but also for several other human diseases. And OMIM is a very highly detailed database on Mendelian inheritance and diseases. Then you have human gene mutation database and so on. There are several public domain disease databases which are available. They are important because once you eliminate the common polymorphisms, then when you are trying to sieve the variants which are extremely rare, and then I will go to the next step, you just don't identify the variant. You go and see where this mutation lies in the protein structure. Has it been documented in literature that it is already causing the disease or not? This information is what you will get from the disease databases. This is all part of clinical reporting. It will be reiterated in my last 3-4 slides. So, and so on and so forth. Now, so where do you compare with? So I said there is so much diversity. We saw so many population databases, right? So we are not identical. So how do we ensure that you sequenced a person here and then you are trying to see if you have, have you done justice in pulling out the right mutation, which is a rare mutation, but not a polymorphism? For that, you need to have a reference genome or a reference sequence. So here again, there are few bodies across the world. NCBI is one such institution which has been working very hard to bring these drafts of human genomes as and when we keep doing more and more genomes. The first draft of human genome came in the year 2000, and we are learning more and more every year as more and more sequencing is happening. So today we are in human genome draft 38. Before this, the draft 19 was considered to be a very relevant and a reference standard across the laboratories, medical laboratories, as a reference standard sequence against which you verify the patient of your interest to look for mutations. So this is another, I will be going, in the interest of time, I'll be going quickly. I'm just describing how you want to look at a VUS variant. I'll be going back and forth. So when you see a VUS variant, this is an ATM. It's a VUS variant. All you look for, it's present in exon 6. How did you classify as VUS? This particular variant was already reported in ClinVar. This is the ClinVar ID that is present. And of course, you are able to classify this based on the ACMG guidelines, AMP guidelines. AMP is Association of Molecular Pathology, American Association for Molecular Pathology. And this variant also has been documented in the DB-SNP as one of the rare variant. So how did ClinVar come to this consensus to call it uncertain significance? Although somebody documented, it becomes very important for us when they documented. It was first documented in 2017. Later on, it was also documented in 2023. Beyond that, there was again an update in 2024 February. So every time a laboratory identifies and documents it in literature, ClinVar takes that interest to review this information and mention it here that we have last seen and this is what is the update. Now, why am I spending so much time here is we need to understand what this VUS is all about. It is a rare variant, definitely in ATM. ATM is an important gene. Therefore, that's the reason why we are looking into it. Why is it important to document this VUS? VUS is anyways not going to help the clinician in any clinical management today. But still we mention it. Why are we doing that? The reason why we are doing that is this particular location, this particular location, 178 prolin, is a very conserved location, meaning you take humans, you take chimpanzees, you take uh, every other species where this ATM has played the similar role in the biology of the organism. This particular location, proline, has always been an important location. Now, when it changed to serine, we don't know what it is going to do. Meaning, does it cause the protein to lose its function or not? That information is not available. Predictions are there. These are programs. These predictions, sometimes they say tolerated, sometimes they may say deleterious. So if they say tolerated, that's again an evidence to say that it is rare. So it's important for me to document. However, proline to serine is a tolerated change in the mutation. Since there is no further evidence on this, I am keeping still this information in the report. Maybe future, there may be some more information that comes up. Another important factor that is given here when this revised information was provided is this variant of ATM, until date, it has not been reported in some of the well-established population databases, that is GenomeAD. GenomeAD focuses not just, this is one of the databases which recently evolved and where they focus specifically on Asian population as a separate window. So when something pops up here and we are making a report, we find a variant, we go back and look at the GenomeAD. So that's how it is important. So now going back to, BRCA1, BRCA2 pathogenicity and how, or rather why, it is important to look at these mutations. Primarily two reasons. You can look at tissue profiling to look for BRCA1 and 2. By doing a tissue profiling or tumor profiling, what happens is you get the information of both the somatic as well as germline. However, it is like a water and milk mixture. You cannot separate them. It is within the testing, but if you can still get some clues. So what are the clues which are here? The clue here is the allele burden or VAF or mutant allele fraction. Different ways all mean the same essentially. So this is an indirect indicator when you do a tumor profiling. Here this BRCA is a pathogenic alteration. This particular patient was 79 years of age. She had two different malignancies. She had a breast as well as she had an ovary. So this is a high-risk scenario, dual malignancy. Okay. And hence, when you go back and look at her profile, If you got this allele burden as 13% or 18%, you will consider that it is an aging related factor, and hence it is a pure somatic. But since it is coming very close to 45, 43%, anything above 40% to 60% is often maybe a heterozygous germline mutation. For such an event, considering she is dual malignancy, whatever may be their age, it is always recommended you do a reflex germline testing, at least for BRCA2, to ensure that she is not a carrier of this high-risk mutation. So another important information that you want to look at in an NGS report here is, what is the scope? We are looking at SNVs, indels. I'll come to it later. That is the scope, then clinical indication. And when you find a variant, as per the AMP guidelines in tumor profiling, it can be hematological malignancies or it can be solid tumors, doesn't matter. There has to be a tier 1 and tier 2 representation in the report. What is tier 1? Therapies relevant to patient's cancer type. Relevant therapies in the same cancer type is tier 1. Tier 2 is if you have FDA approved or NCCN approved relevant therapies in the different cancer, it is important that you document that. It is more like a off-label information. It's not necessary that it is going to work, or even if there is maybe there is no evidence also. But as per the guideline recommendation, it is important that we document this information. And then the other important aspect that one has to look when you are looking at a BRCA mutation is what type of mutation and which exon it is present. Okay. And the other thing, as I said here, in the US, did you see that variant in ClinVar? If you have not seen, how did you classify it as pathogenic or VUS, whatever? These are by guidelines. So what are those guidelines? I'll come to that. So here, this particular variant, nature makes mutations in BRCA1 and 2 or any tumor suppressor for that matter during oncogenesis, where most often you will find a novel mutation. It's not necessary that you should you do get recurring mutations. When you get recurring mutations, it becomes available in databases like ClinVar. But if you get a novel mutation, how are you going to assign its pathogenicity? You have to have some kind of a scientific evidence with you, either a literature evidence for the same variant or its location in the protein sequence that confirms that it is pathogenic, means it was reported in a disease-causing individual. So another information that becomes important while we document is, if you have any other contradictory evidences for the information that you have identified, it becomes important from the laboratory perspective to inform as part of the report. Here is the information which came out last year about the olaparib, not the remaining PARP inhibitors. It has been withdrawn for the indications in the beyond a few lines of therapy. So here you see coverage is given, as I mentioned earlier. So in fact, I have not shown, in the interest of time and also space, this particular BRCA variant that we identified in this patient. Apparently the patient did both tumor and germline, and it was found in both. This further confirms that it is a germline origin. So that helps saving time, because you can counsel the family members for the subsequent screening process. So what more information do you have about this variant? I was saying that, right? So this variant is not found in any of the population databases. That means it's not commonly present in the population. Prediction tools are predicting it to be deleterious, as I said. And how am I going to confirm that this particular variant is important variant? Because I don't have any evidence in the literature to confirm this, right? The next evidence is, where is this particular located mutation? It's located in exon 27, which has the nuclear localization signal and the RAD51 binding location for BRCA2 protein. So these tumor suppressor are mostly nuclear proteins, right? If you do not have the nuclear localization signal, the protein does not do its function, what it is necessary to be done. Because it is present here, it becomes important functionally, as it was earlier documented in the literature. So any mutation present in this particular location is suggested to have a loss of function. And that is why it has been classified as pathogenic. So functional domain, where it is located, how important it is also another evidence that helps us to classify it as pathogenic. This is another case. Here it is a very different type of mutation. This is called a splice mutation. Splice mutations are not exactly present within the complete exon. They are present in the exon intron boundaries. Introns are non-coding regions, right? So they are present in the exon intron boundary, 2 alphabets plus or minus 2 on the exon intron boundary is where a classical canonical splice is observed. So what happens when there is a splicing event? The protein does not produce the wild type, the gene does not produce the wild type protein. It loses its splicing information in this location. I will show you that it subsequently. -1G, meaning it is 1 alphabet into the intron immediately after the exon on the negative side, not on the positive side. So here, when it is a splice variant, this is happening, a mutation at the DNA level. Nobody has seen the protein. In the previous example, it is happening right inside the protein. There is a protein location that was there. So if there is a termination, yes, it's going to be pathogenic. But if it is happening in the intron exon boundary, how are we sure that it is actually a causative variant? Here one has to be extremely careful. If you have an evidence, it becomes straight pathogenic, meaning this evidence essentially says that they found an affected individual in a group of family members. Affected member only had this splice variant, whereas the non-affected people did not have. That goes with a clinical genotype-phenotype correlation, and hence it is a strong evidence. And that's the reason you're able to call it pathogenic. If you did not find this evidence and you're purely going with the canonical splice variant, you should not call it pathogenic. You have to call it likely pathogenic, because it's at the DNA level. You have to see what happens to mRNA, what happens to protein. Who has seen the evidence? That's why we call it likely pathogenic. It is still important because it's happening on the transcript, which is canonical transcript. What is canonical transcript? Canonical transcript is the transcript which is used for cellular homeostasis. That is the longest coding gene which produces the protein required for a healthy cell to survive. So these are certain criteria. How, as I said, as I was walking you through the pathogenic, most of it information is here. You have, its a variant is novel. So the previous variant which we saw, the one which we before, it's not reported in literature. That frame shift variant, purely based on the functional evidence, loss of gene function based on its pathogenicity or scientific evidence. That was one important information. Of course, prediction tools was also there. And we did not have, it's not, we don't know whether it is de novo or it was already there before, because we don't have the family history here. So certain factors we need to take into consideration. This is yes, or this, or this, or this, or at least 3 to 4 factors should come together before you can stamp it as a pathogenic variant.
Vidya ma'am, I'm so
Yeah.
sorry, but hate to cut in. We should wrap the session by 4:30, ma'am.
What is the time now?
It's 4:25, 5 minutes to go.
Oh my God. Okay, when BRCA is negative on NGS, we look for large deletions and duplications. So essentially, this is a negative region. When you see these dots coming up below, above the green and the blue line, there is a deletion. Now I'm going to CML, sorry. Let me quickly go through. So we all know about the major, minor, and micro BCR ABL. So essentially it is all where the breakpoint is between exon 13, exon 14 of BCR, or exon 1 of BCR that happens in micro, or it can be, exon 19, sorry, in micro BCR is ABL. So these are the levels of information when you are trying to look for a disease, particularly CML under the microscope. Cytogenetics is the most crudest version, where by doing G banding, you are trying to look at greater than 4 into 10 to the power of 6 alphabets. These little bands, each is a DNA segment of that long. But when you are coming to fish, you are going at 10 to the power of 3 alphabets. 14 to 10 to the power of 3 alphabets is the resolution that you are giving by fish. And when you go to NGS, or Sanger, you are looking actually at individual alphabets. That's the gross difference in terms of resolution of information that you get about a mutation or a translocation. So this is the procedure that one adopts. Essentially, in cytogenetics, you have to arrest the cells in metaphase, and then you spread the chromosomes, and then you look at it under the microscope after you do a G banding. G banding essentially trypsin, it's a trypsin enzyme that goes and digests the DNA, which is accessible, and that becomes white in color. All that black, dark locations are essentially tightly packed DNA. White is loosely packed DNA. And this is the 9th chromosome 22, and you see the BCR-ABL, which is bent on the left here. Because 9, both are 2 copies. They don't look identical. It has lost its head here. Okay, in fish, what happens essentially is you can do fish in metaphase or even in interphase. If you do it in, whether you do in metaphase or interphase, you have to open up the DNA. That means you have to denature and break the hydrogen bonds. Then you put the probes on it. It hybridizes it, and then you observe under the microscope. So this is about the, what are the limitations and advantages, sensitivity level between the different technologies. So this is something called as fluorescence resonance energy transfer. 2 different fluorophores, BCR and ABL, will have 2 different colors. When they come together, energy is absorbed by pink and transferred to green. During this process, there is some amount of energy that gets released, because of which the color comes out as yellow. Okay. So that is what is essentially BCR-ABL under the fish microscope. So elements of NGS, I still did not go into IRMA and qPCR. So this is one important information for all of us. All people talk about depth of coverage. So I told you about the consensus reference sequence, right? This is your patient's data. 2 many different fragments of DNA. So you have to get 5, how many times you read this region, reference region on your patient sample, that much confidence you are building. So that is what is the depth of coverage. So this region is essentially, although it is not covered by the same segment of DNA, it is covered by different stacked segments, still the purpose is solved. And that is why it is called high coverage, whereas this region is low covered region. So this was something I talked about, the variant prioritization and all. And important elements of NGS report need to have evidence information about the drugs that one provides. Is it FDA approved? What level of information is available? It's important to remember, notify the exon number, which we discussed earlier, and allele frequency and relevant literature evidence, if any, in a given population, and scientific evidence. And most important is the okay. Just of time. So another important information that one has to look at in NGS report is what is, as I said about the coverage depth, what coverage this particular assay is providing. So one has to remember that there are two chemistries in NGS. One is amplicon chemistry, another is probe chemistry. In the probe chemistry, beyond 250x is good enough to get good results. Whereas in the amplicon chemistry, there are PCR duplicates, meaning it's not the true signal. The same signal gets repeatedly amplified, which is not going to give you the true picture. That is the reason why you have to collect more data in amplicon, where you will go beyond 1000x to see the actual results. And in every assay, it is becoming very important that you have to show what are the assay's quality parameters. That is its limit of detection, essentially. 5% for SNV, 10% inverse. And when you look for copy number gain, it should be, what did the lab develop and establish? And of course, it should say that it has not been cleared or approved by FDA if it has not been, and what guidelines are being followed. And if there are certain regions that are not covered, it becomes important that you mention that explicitly in your limitations and disclaimers. And just a couple of reports that I want to show. Shall I go ahead? I'll just quickly cover because that was an important topic which was told to me to be covered.
Yes, ma'am. Maybe 5 more minutes, ma'am.
That's all. Yeah. So we all know CML, BCR, ABL is a very important thing for MRD assessment. And we all know about the cytogenetic response. Then you have the first is the hematological response, then cytogenetic response, then the complete cytogenetic response, and the major molecular response. So this particular table is very, very important for us. Complete hematological response means in the blood smear, you are not going to see blast cells in a regular peripheral, blood smear or BMS smear maybe. Most often it is BMA that is required to demonstrate it has reached a CHR. Major cytogenetic responses, when you try to observe the chromosomes under the microscope, either by the traditional method or by FISH method, you are seeing anywhere between a range, not 100% cells are female positive blast cells, anywhere between 1 to 35%. If you don't see even a single cell on the microscope, that is usually you do 500 cells or, sometimes 200 cells or 500, depending on what kind of blast, how good is the marrow. It's important to document that we did not see even a single cell on the either FISH or by conventional cytogenetics. Then comes the major molecular response, where your percentage for BCR, ABL, IS is less than 0.1. Then so what is this? Why all this IS has come into picture? So for that, I had shown earlier. So what is this CML management? Essentially, it's all about looking at the BCR, ABL, mRNA copies, essentially count the mRNA copies, divided by ABL copies into 100. It's a simple thing that we do in real-time PCR. But different labs will use different reagents coming from different vendors. So where exactly this ABL probe is binding? Because ABL is a big gene, right? So which location it is binding? Because RNA is prone to degradation. And are you looking at a conserved region on ABL? Definitely, most of the labs will try to adopt one certain thing. but there will be slight variations in the reagents that are being used between lab to lab. And what happens therefore is there is no there is no consensus, or rather there is no concordance that comes up between different labs. Some labs earlier, before this IS story came in, people used gus, people used several other not just a beta 2 microglobulin, different housekeeping genes to look for the BCR-ABL fraction. So when you have different housekeeping genes, your fractions will change because housekeeping gene expressions will change. To avoid all this confusion, the IS came into picture. Essentially, this was suggested by WHO. It is again an RNA where you know a known copies that is known to be present for BCR-ABL. So that will when you run that IS sample with your patient sample, you will look for the burden of the IS sample also. And you are also looking at your patient sample that essentially becomes the control. And along with the kit, you get something called as a conversion factor for that particular IS reagent that you are using. So every time you do this, you are multiplying your conversion factor with the BCR-ABL by ABL ratio. That conversion factor essentially it's nothing but it's also derived from the same BCR-ABL mRNA. It is like some other patients, ideally some CML patients, ideal blood sample, CML patients, ideal. And it's important to run that to compare with the remaining patients which you're running in the batch. When you do the correction factor, you ran the sample today here, or you ran it in some other lab across India or the rest of the world, your percentage is not going to change. So that was the main reason why BCR-ABL IS came into picture. And it is very, very important to know how many copies of BCR-ABL are observed in the experiment. And 10 log reduction, 1 log reduction, 10 log reduction are some things which we need to constantly monitor while we are trying to monitor the response. So, so this is the percentage ratio as per the lab, but when you do it with the international case conversion factor, its actual percentage is 62%. And let me move on to the IRMA. In the IRMA, my major thing, all of us know about IRMA, but I want to, insist on one very important and interesting database for clinician standpoint. Civic is the database where they have spent a good amount of time in trying to collate all the IRMA mutations here and their case studies with relevant information. How many patients were there in that study, which drug was given, and what was the outcome that was seen, and how many times it has been reported in the literature. So we have roughly 202 entries of BCR-ABL fusions where ABL mutations are documented. So when you go to the first, the very first one is the T315I. But there is more to it beyond T315I, which we often come across in our routine practice. Now, how do we provide this information as part of the report when you are making an IRMA report? You have to look at database is one way. The second thing that you probably look for is literature evidence. Have you seen such a mutation elsewhere? Then which drug had worked in a second or third generation TKI for the ABL kinase? So this is an important information which we always used to refer while making in IRMA reports. And that's the reason why I thought I'll show this information here. All I did was I went to the database in the Civic, I typed in ABL1, and this is what I get. And that's what it is essentially. And it provides plenty of information in terms of studies and their evidences, and how many patients had that in that given study, did they respond partially, completely. All the information is here. And moving on to the IRMA report that I wanted to walk through. So IRMA is looking at the mutations in the kinase domain of BCR-ABL, essentially the ABL1 gene of the BCR-ABL fusion. One has to be very careful that you don't try to sequence the ABL gene alone. So you have to ensure that you are taking the sequence from the BCR-ABL transcript mRNA and then you are trying to sequence it, because ABL gene is ubiquitously present in the normal leukocytes also. So you need to make sure that you are checking on the BCR-ABL mRNA.
Ma'am,
There is
hate
a
to
challenge
cut in.
with, yeah.
Ma'am, hate to cut in, but we need to wind up the session, ma'am. We are exceeding the time limit.
Okay, only one important take-home message. IRMA usually is done by Sanger, but one important measure that everyone should remember in the clinic is, if you do it by Sanger and if your blast count is less, you will be very unlikely that, you will be having high chances of false negative report, because Sanger as a technology can pull up only any mutation beyond 20%. So IRMA is best done by NGS. That is an important message in the clinic. And that's it. I mean, I think I will stop here and thank you for this opportunity.
Thank you so much. That was a very valuable session. Thank you, Vidya ma'am and Sweta ma'am, for such an immense and still a very crisp presentation. A huge thanks to all our speakers today for such an engaging discussion. Vidya ma'am, Sweta ma'am, Sameer sir, Abhishek sir, and our speaker, Dr. Ashwin, and obviously the examinee also, Dr. Nitya, for such wonderful and in-depth discussion. Hope all the students have benefited with both the practical as well as the theoretical approaches. So with this, I thank Amrita E. Gurukul for such a vast discussion in both the practical and the theoretical aspect along inclusion of the drugs and all. A huge thanks for everyone. So with this, we would like to conclude our today's session. Thank you again. Thanks, Amrita E. Gurukul. Thank you all.